Right guys, so once again, sorry I was a bit late. I just came straight from work. Traffic's really hectic because of the snow, so I just once again to introduce myself. My name's Adil. I studied at Leeds. A lot of you might recognise me. I basically used to just pretended like I had friends in the airport lounge and just said hi to everyone, so that's how probably you guys know me. This is Hamish, we just met the other day. He's actually a really nice guy also. We worked really hard on this. One thing though, this is going to be as interactive as possible, so I'm going to be asking questions. Now, I know that a lot of people get really shy, so I brought a fake Twix as a prize. But this is not ordinary Twix. Basically, when my dad goes shopping, he thinks of me and buys me these chocolates, okay? And then my mum, she takes it out for me in the morning, bless her. She's actually suffers from stroke, so it's a bit of a struggle to get up in the morning. She comes downstairs, takes it out for me and leaves it on the counter. So basically it's filled with my mum and dad's love. And that's what got, in all honesty, that's what got me through med school. So, mum and dad's love has a 100% success rate of passing finals, okay? So, you really want this chocolate. Please be interactive. There's no such thing as a stupid answer, no such thing as a stupid question. At the end of the day, I've been in your situation, and trust me, I wasn't a poor medical student. Let's just say, you know, I left a lot of things to last minute, so a lot of the time I was playing catch up. Hamish is going to go first, and stop us at any point as well if you want to ask us anything or just to say hi. Yeah, that's what I used to be.
Hi, I'm Hamish. Right, so let's start. Right, I'm going to need a volunteer for scenario one. You have to sit there, you're just going to answer some questions that I'm going to ask you. And if you don't get it right, then it's open to everyone. Okay, don't all jump at once.
I'll volunteer, but I won't get it right.
Okay, that's fine. That's fine. The first one's always the easiest one, so you've done right. Okay, so you got a 19-year-old man comes into A&E, short of breath, alright? Nurse has told you he's finding it hard to breathe, and what she knows is that he's got no past medical history of significance. She did the obs while you were coming down to A&E, and those are your obs, okay? So SATs 92, breast rate 26, heart rate 105, BP's normal, and apyrexia. What would you do?
Well, I'm not happy with the stats which were training heart rate, so I'd be thinking ABC first.
Yeah, that's exactly right. So, yeah, go on. So A,
airway.
Yeah.
Does he talk to me?
So he's talking a few words, he's a couple of sentences, not great though.
Okay. B, so I've seen his stats. I put him on some oxygen straight away.
Yeah.
For a minute.
Okay.
And check his examination.
Yeah, that's where you go with examination, right?
Okay.
I'm going to help you, I'm not trying to trick you out. So it's a bit of wheeze and there's not much else.
Okay. C, I'd get a large bore cannula or a cannula in.
Okay.
And I'd take a pulse, and I've already done that.
Yeah. Yeah, so part of it's already come, right, so it's normal. Alright.
Okay.
Anything else you want to do, part A, B, C, D?
I'd take the bloods.
Before you do that?
Before I do that,
Have you heard of has anyone heard of A, B, C, D, E, F, G? Yeah. So do it every time, even though it's not really important in this case. Just do it every time, so the one time when it is important, you don't forget it.
So...
Okay, so there you go, right?
Oh, okay, yeah.
Okay, so just, like again, you said your immediate actions would be oxygen, right? Yeah, okay, and you said you put cannula in as well. Okay. Anything else apart from the oxygen? So, sorry, just going back a second. So what do you think, what's your differential at the moment? What's your main diagnosis that you're thinking you need to come in with? Yeah, there's a couple that you want to think about. So anyone who's short of breath, you want to think of the respiratory and the chest ones, but with him, he's fit and well, his SATs are low and he's got wheeze, there's nothing else wrong with him. So you're probably thinking it's asthma. Okay. So the next bit is basically your asthma. So you got the first bit, so oxygen. It's an asthma attack, yeah. So do you know how much you want to give him?
5 in the nebulizer?
Yeah, so 5 milligrams.
5 minutes.
Yeah. So yeah, just over a few minutes. Does anyone know how much salbutamol you can give someone? Sorry? A lot. You can give back to back. Basically, you can give it however much you want. As long as you don't give it in excess, you're not giving them about 20 or 30. But there's no definitive, there's no upper limit. You just need to be careful about giving so many back-to-back nebulizers that you might decrease their serum potassium levels. Okay? Okay, so you've got IV access and bloods as well. What are the other investigations you want to do? Actually, that's all right, thank you, all right. I'll let you breathe. Someone else now.
ABG.
Yeah, ABG. What are you looking for on the ABG?
Oxygen sats, and you want to look at the lactate as well.
Yeah.
Just in case it's
So, oxygen, lactate, and one other thing? CO2, yeah. Why are you looking at the CO2?
Taking it rather than
Yeah.
doesn't like it.
What would you, so in an asthmatic, so this is an exacerbation of asthma, what would you expect the CO2 to be? Less than normal, high or low? Yeah, exactly. Anything else you'd want to do? Yeah, chest X-ray, just to rule out a pneumothorax. Okay. So what would you want to monitor in this patient? It's an asthma attack. You've given him the nebulizers. ABG just shows type 1 failure. It's just hypoxic. Chest X-ray is normal. What do you want to monitor specifically, and how often? Yeah, so SATs is one thing, and one other thing we've not discussed yet that you'd want to do in this patient.
It's peak flow.
Yeah. And if it was, so you want to do it when he comes in, but if someone's really unwell, you're not going to say, right, blow into this first, then I'll give you some oxygen, are you? So you're going to do the oxygen, so it's going to be a bit distorted, but you can do it when you can, and you normally want to give it about 20 minutes, do it 20 minutes after a nebulizer to see what effect it's had on them. Okay, so the bloods are sent off. That's your ABG. You expecting that? You happy with that considering they've got asthma attack, or are you a bit concerned? Sorry?
I'd expect that.
You'd expect that. Yeah.
He's on 15 litres.
Yeah, so you'd want to increase his oxygen if he's not already on 15 litres, okay? Say that the oxygen is fine and that it's still a little bit low, but say it's about 20 or 30. What about the CO2? Yeah. Does anyone know the normal range? Yeah, I think a few of you said it, about 4.5 to 6 on average. So this is the normal CO2, so should be quite concerned. Right, chest X-ray, there's nothing. Diagnosis, right, we've already said it. Okay. And then you've done his peak flow as well, and it's 35%. Before we get to that, so does anyone know the severity of asthma scale? So moderate, severe, life-threatening, or fatal. With what you have here, does somebody want to tell me what it is?
Less than 33% is life-threatening.
Yeah. What about the CO2?
That makes,
It's normal. Does that make it moderate, severe, or life-threatening?
that makes it fine.
Yeah, so it's life-threatening. Basically, to scale, to find out what asthma is on the severity scale, you only need one marker in each group, the more severe group, to make it that classification. So most of it is severe asthma in terms of the SATs, the peak flow, but because the CO2 is normal, that makes it life-threatening. Okay, where are we up to? Who's next? You already know the question, so if you can answer it for me.
IV hydrocortisone.
Yeah, so you've got IV access. Do you know how much you'd give?
200 milligrams.
Yeah, and if you can't give hydrocortisone, what would you give? Yeah, about 30 or 40.
Why is, sorry, I've asked you a question. Why is that hydrocortisone so
Why is
Is it
what?
how it works? It works after.
To be honest, IV hydrocortisone and prednisone work in the same way, and work in a similar amount of time. It's not an acute fix. So whatever don't expect steroids, they're all of a sudden going to jump back. It's not acute. It's for something to kind of stop it. Well, while the acute management's going on, it's kind of to work with it to stop it from kind of regressing.
It normally takes about 4 to 6 hours for it to start working to have an effect on the inflammatory process. So we've already talked about that. But the patient's not improving, the chest's still tight and they're wheezy, okay? The SAT's not improving either. What's your next step? The guy with the red, yellow bottle. Black jacket. Right. That's right. What would you do next? So he's not improving, you've done the nebs, you've given him steroids. Steroids aren't really going to make a difference at this moment in time. So this is the next step up, really.
Get the protocol out.
Okay, fine. Anyone else?
Cherry bromide.
Yeah, you can give that as well with a nebulizer. Think about the next step. Fine. There's one more thing you can do before you're thinking, right, this is a little bit out of my depth. Yeah, magnesium. Magnesium's the one. So you want to give them magnesium sulfate. Aminophylline, you won't be senior enough to give, and in this trust anyway, the respiratory consultants, they're in disagreement, so it's not really your call to make. How much magnesium would you give?
Can F1s give magnesium?
Yeah.
Yeah.
But when you get to this stage, you're thinking, right, I need a senior review. This is the level which you should be able to manage. But even before that, if they're not responding on nebulizers and you're thinking, I'm a bit concerned, you can get senior help, but you can prescribe and give magnesium sulfate. How much? Yeah, 2 grams, yeah. And root? IV, yeah. Okay, and as someone else said, yeah, you think about aminophylline, getting senior help, and you probably would want some ICU input if they're not responding to any of those. Okay. So just for some of you a little bit unsure, that's the severity scale. So you just need one of anything for it to be either moderate, severe, or life-threatening. And the most of the stuff you can get from your history examination, there's only a couple of things that you need investigation, such as your SATs, you need a SATs probe, or your oxygen and CO2 levels. And if you're retaining CO2, which means your CO2 is rising, that means it's near fatal, which means you need intensive care input. Okay. What makes you think a patient's ready for discharge? So you've treated them as stable in the hospital. What makes you think that you're thinking about getting them home?
The peak phase factor greater than 70% of predicted.
So yeah, 75%, yeah. So if it's stable for at least 24 hours above 75%, then that's one of the criteria. Another one is quite simple, really. They think that they're ready to go home, because a lot of asthmatics, especially the chronic ones, they know when they start to feel a lot better, all right? And there's one other thing, that they need to be off nebulizers for at least a day beforehand as well, because obviously they're not most, if not all of them, are not going to have nebulizers at home, so it's important that they're off them whilst they're in hospital. And just a few things about advice on discharge. You want to check their inhaler technique before they go. You want to discuss their triggers and allergen avoidances. It's not really related to this case because this guy's, well, the case was a new onset patient. You'd also want them to do a peak flow diary. Has anyone heard of an action plan that you'd give to asthma patients? Yeah. So it's if someone's peak flow goes below 80% of predicted or estimated 60% and 40%, there's a couple of things you do. So if it goes below 80, you tell them that once they recognize that's gone below 80, you want them to increase or start using their inhaled steroids. If it goes below 60, to start an emergency course of steroids and seek medical attention. I've not added that on. And if it's less than 40%, to seek emergency medical care. Okay.
Is that oral steroids?
Yes, yeah, that's oral steroids. And when you discharge them, if they've had an asthma exacerbation, you want them to get followed up by an asthma respiratory physician in about 3 to 4 weeks. Okay. We're going to skip past COPD. Just a quick answer that I need. What's the difference between infective exacerbation, COPD, and pneumonia? In terms of, you've got 2 patients who come in, both have got COPD, both are coughing, unwell, short of breath, reduced exercise tolerance. What investigation would you do to differentiate between the two?
X-ray.
X-ray, yeah. So you're looking for consolidation. If this is consolidation, it's pneumonia with possibly underlying exacerbation COPD. There's treatments on here, but I'm going to email the presentation so you can get this online, so I wouldn't worry about getting any of this down. And if people get really severe COPD, you give them non-invasive ventilation, and this is the kind of mask they put on. It can be quite just claustrophobic as well. Right, next volunteer. Trying to pick someone.
I call anyone. Is everyone willing to just shout out at random then?
Yeah, okay,
Is that
fine.
right?
Okay. Right, 16-year-old girl comes in with nausea, vomiting, general abdominal pain over the last 12 to 18 hours. You go to see her, what's the first thing you do? Yeah, true. One thing you do before that. But
Introduce yourself.
yes. Yeah, exactly. A, B, C, D. Okay. So her airway's patent. Respirates are slightly high, 22. She's got deep and laboured breathing. Okay. Chest is normal though. She's borderline tachycardic, borderline hypotensive, cap refills prolonged. She's got really high urine output, but breath sounds are normal. Okay. In terms of neuro, she's stable. Stats are fine. Okay. BM is 26. What are you thinking is the most likely diagnosis? Yeah. Okay. So you've got the vital parts of your examination. What's the first thing you'd want to do?
ABG.
Stats are 100%. You can give them some oxygen. It's not going to harm.
Urine, ketones.
Yeah. Is anyone worried about the heart rate, blood pressure?
Fluids, fluids, and then starting into this one.
Yeah. Okay, so you want to start some IV access and fluids. Basically, the management plan for DKA is, giving them fluids, and then, as someone said before, after that, giving insulin as well. Do you know what type of fluid you'd want to use in a DKA patient?
Potassium in the second 100.
Yeah.
Or
So.
she's depleted.
Yeah, so basically you need to treat what's in front of you. You can't give a tick box kind of answer for DKA. If she's in shock, you'd want to give the first bag straight away, and usually a lot of them are because they're quite dehydrated. So you want to give the first bag quickly, basically stat, and you want to use normal saline. And you wouldn't want to put anything in that. And as the guy at the gentleman at the front said, after that you want to start putting some potassium replacement, because in DKA not only are you using fluid, you're losing sodium and potassium as well. How much potassium would you put in your second bag?
20
No.
Yeah.
According to what she looked at her potassium.
Yeah, so it's important to check the blood and to do it accordingly to that. Okay, these are some of the other investigations you do. Okay. So what do you need to do to diagnose DKA? So you've got the capillary glucose, that's high.
Urine ketones.
Yeah. So is there any other could you find ketones anywhere else in the body apart from the urine? Breath, yeah. And in the blood as well. And so you've got the high blood sugar, you've got the ketones. What's the last bit you want to know? Acidosis. How are you going to show that?
ABG.
Hands up, how many of you would do an ABG?
No, don't do it. Because they won't come back.
You could do an ABG and that will show you acidosis, and it's probably the quickest way. But the thing is, that's now kind of classified as being a bit, not negligent, but being a bit harsh towards your patients. You can get it from a venous blood sample, and so you do a venous gas. Do you know what you're looking for on a venous gas? Not lactate, no, you want to look at the bicarb. And basically you'd have a low bicarb, and that's enough for your diagnosis for DKA. Okay? So raised blood glucose, or capillary glucose, ketones in your urine or in the blood, and a venous bicarb. Okay? You can do an ABG, but it's recommended that you don't. So do you know, after you've given the first bag, and then you've given the second bag, and you put some potassium in there, because the potassium, you need to replace it. Over how long would you want to give the second bag now?
2 hours. 1, 2, 8 hours.
So I've got 2 hours down here. So everyone agree, or does anyone think differently?
After the first.
Yeah, so it used to be 1 stat, 1 over 2 hours, 1 over 4 hours. Now it's a little bit different, okay? That doesn't matter. It's when you give stats, then you'd give 1 over 1 hour. Oh, wait there, I'm getting confused myself. Okay, so there you go. So you just cut to the slide. So you give 1 hour stat, then you give 2 litres over 4 hours. So 1 over 2 hours, 1 over 2 hours, then 1 over 4 hours, and then another 1 over 4 hours. Okay. It's quite a lot of fluid to give, so you want to look at their blood pressure and their heart rate and do it according to that, just to see how fluid depleted they are, or make sure they don't get too overloaded. Okay, so as that's going through now, they're starting to get more hydrated. You want to give insulin. What kind of insulin do you want to use? Actrapid. Anything else you think you could use? Humulin S as well. You can use that as well. Do you know how you'd mix it together? What you'd mix it in? What you'd give it with?
The units, 50 mil, and in saline.
It used to be like that, but it's changed recently. You'd want to give 0.1 units per milligram per hour. So it works out to about 6 or 7 units an hour for a normal 60, 70 kilogram male or female. And you'd want to mix it with some normal saline as well.
Right, can you say that again? You give what? 0.1?
I've got it here on the slides, you can write it down if you want.
Are these really, how recent are these changes?
It has been. It's been around for a little bit, for a while, but there's a website then that you can go onto if you want for the diabetic emergencies. It's one of the diabetologists gave this presentation just a couple of months ago. There you go. So you want to give 0.1 units. So for every 10 kilograms, you want to give 1 unit per hour. So it works out to about 7 units now in a 70 kilogram male. And so while it's above 14, you're not really worried about the blood glucose. You don't want to give any dextrose. But after that, you want to think about bringing down the rate of insulin. So when it gets between 5 and 14, you might want to halve the rate of insulin and change your fluids from normal saline to 5% dextrose. Okay. And just a few things, these are a few complications of DKA. And if you think about it, if you're giving someone loads of fluids, pulmonary edema and hypokalemia, they're two of the things that you can, cause yourself, as well as it being a complication of DKA. So it's quite important that you look at the sodium, potassium each time that you fluid replace them. Okay, so in a DKA patient, if the potassium is more than 5.5, would you want to add potassium to your fluids? No. 3.5 to 5.5, would you want to add potassium to fluids? Yeah, you'd want to, because basically you've got a normal level because the potassium's shifting from the cells into the blood. So there actually is a state of hypokalemia. It's just that all the potassium's gone from the cells into the blood. And at less than 3.5, you'd want to replace. Just a couple of rules. Never inject it neatly. You're going to kill them if you do that. And if you give someone Hartmann's, this is just in general, not for DKA, you can't add it to Hartmann's because it already has a pre-mixed amount of potassium in there. The maximum you can put in a litre bag of any fluid, such as normal saline and 5% dextrose, is 40 millimoles. And you can't infuse it at a rate of more than 20 millimoles an hour. If the potassium's above 3 but less than 3.5, you could probably give some oral supplementation. Okay, there's a few things on hypoglycemia and hyperosmolar state, but we'll go past that to our next scenario.
Can I just ask a question?
Yeah.
Why can't you add potassium to the Hartmann's? Is it because it's already got potassium?
Yeah, there's already some potassium in there. It's not very much at all, but it's just one of those things you can't add potassium to Hartmann's solution.
Potassium is
No, you wouldn't. But people are very sceptical, especially nurses, quite scared about potassium and adding it, especially to people with low potassium. You'll find it as you start working that it's quite a big thing, checking the potassium, make sure it's all okay. And people are quite sceptical, quite scared at giving potassium. So normally you'd only give potassium through normal saline or dextrose saline, basically.
Also, Hartmann's is more physiological, but it uses lactate rather than chloride, whereas normal saline is sodium chloride, right? Hartmann's is actually lactate rather than chloride, and when you're adding potassium, you add it as KCl, so you're adding chloride into it, so you're kind of missing the whole point of it being physiological. So that's why I think it's one of the reasons, but I just came up with that answer. I'm not even going to lie. But yeah, it's just because it's pre-mixed. It's meant to be physiological. You don't mess with it. If it ain't broke, don't fix it.
Right, next scenario. You get bleeped at 9 o'clock in the hospital and the blood's come back for Mrs. Smith on a ward. Potassium is 6.4, but the nurse says the patient seems okay. So you come to see the patient, what would you do?
Do ECG.
Yeah, you can, I put ABC on the next slide, you can do that. It doesn't take you that long, but it's not a problem. He's talking, everything's fine. Okay, so you want to do an ECG, there are no changes. What would you want to do now?
Redo the bloods because it can easily be a false reading.
Yeah.
Like venous gas and checking
She's got kind
Yeah, you can. Yeah, that's important. I put that in because as a house officer, every time you go to see a patient that you're asked to see, whether they're ill or there's something not right, you always look for a cannula because it saves you doing a job. But it helps. Yes, so you want to recheck the bloods because they could have hemolyzed. But basically you want to investigate. If you think that it is actually a true result, you want to see what's going on. So you want to have a look at why they've come in, see if they've got any past medical conditions or any drugs that are causing this high potassium, and see what fluid's been given, whether it's iatrogenic cause. Okay, you repeat it 20 minutes later because you're still a little bit concerned because you haven't got a clue as to what's going on and there are changes present. Okay. Quickly, let's talk about changes. What would you expect in hyperkalemia? So tall tented T waves. Absent P waves. Broad QRS. And when it's really severe, do you know what it looks like? You probably won't see it because they probably should be dying. You get something called a sine wave pattern. If you've done maths at A level, you know it looks just like a wave like that. And that means that they go in at any stage and you need to do something seriously. Right, so the first bit I've given it to you anyway. Right, so you want to give calcium gluconate. How much would you want to give? Sorry? Yeah, 10 mils, 10%. How quick? Yeah.
How quickly?
10 minutes.
Yeah, well, you can give it around 5 to 10 minutes. Anything like that. Do you know what the maximum dose is? So how many times can you give 10 mils, 10%? Close, yeah, it's about 4 to 5. You can give it up to probably 5 times. But you'd be a bit careful about how much calcium you're putting into the blood as well. Okay, I'll probably give you the next bit now. Right, I'll just give it to you anyway. Right, so you want to do insulin dextrose. How much insulin would you want to give? 10 units, yeah. And over how long would you want to give it? 5 minutes, 10 minutes, 15, 20, 25, 30, 35?
Sorry.
Yes, you want to give it over 30 minutes. And what would you mix it with? Yeah, dextrose, 50%. That's what it says in the books. So if you're struggling with IV access and you don't know when the access is going to come, what could you do to make sure to drive the potassium down? Yeah, salbutamol nebs. And when would you want to, say you've got the calcium gluconate and the insulin dextrose, when would you want to recheck potassium? How soon? Within the first 10, 15 minutes, first half hour? Yeah, so once you start treatment, you want to, after about half an hour, you want to check potassium to see whether your initial management is working, and then you want to recheck it in about 2 hours again. Both of these things and the salbutamol nebulizers are just driving potassium into your cells. It's not actually correcting the high level of potassium in the blood. Okay. Is there anything else you think you can give that will cause you to excrete the potassium? Calcium what, sorry? Yeah, that's the one. Yeah, you can use diuretics as well, but to actually treat the hyperkalemia directly, you'd want to give calcium resonium. Okay. And dialysis is the main thing that can correct underlying hyperkalemia, although most people won't need it.
So is there certain people that need the calcium resonium?
I've not seen it being used at all. For the patients that I've... Sorry?
I think it's for people with chronic anemia for a long time. So
chronic hyperkalemia.
Yeah.
But also, you got to look at it. You got to look at the reason why they went into hyperkalemia in the first place. If it's a lot of them have kind of renal problems, and like I said, it's a chronic problem. But calcium resonium actually works on the dietary intake of potassium. Okay, so a lot of people will argue, oh, this guy's in renal failure, that's why the potassium's up, so calcium resonium's not going to do anything. That's not true. At the end of the day, whether it's dietary cause or renal cause, you still give it to them because you just want any way to reduce the potassium. You know what I mean? So whether it's chronic or acute, just if your initial management hasn't worked, or you find that every time it does work, it's slowly creeping back up, just I don't know. It's not going to harm them.
Okay. Any other questions about that, or anything else so far? It's a bit of what we talked about. Symptoms and signs. Usually most people won't have any at all. And you can see here, the tall tensor T waves are here. You've got to take my word for it, it's a broad QRS, and you can't see the P waves on here at all, although it's still in science relevant. Okay, so you've got a 40-year-old woman comes to A&E. She's admitted to taking paracetamol overdose. She's also been drinking.
Can I start?
Yeah.
You didn't mention subusable nerves.
Yeah.
Are they not part of the guidelines now for hyperkalemia or?
No, we did.
We did mention it. Yeah. We did mention it. If you give 10 milligrams salbutamol nebulizer, so 2 5 milligrams back to back, that'll decrease your potassium in your blood by about 0.5 to 1 millimole per litre. Okay. So if you give them 4, that'll decrease it by about 2. That's not correcting it, so it's not to say that they might not become hyperkalemic in the next 6 hours, but it buys you a bit of time to try and get IV access and find out what drugs you need to stop or how you need to treat them.
And plus, a lot of patients will pull the cannulas out. I've had a schizophrenic patient who pulled up 4 cannulas in one night, and his potassium was just going up and up and up. So, yeah.
With the DKA, if they've got low potassium, would you correct that before you give your staff fluid? What would you do?
You'd give. What's going to kill them first? The shock or the low potassium? Shock, yeah. So it's just basically going back to A, B, C, D. So you want to treat that first before you think about what else you can treat at the same time. But it's right, after the first bag, you'd want to then start putting potassium replacement in. But like I said, you need to make sure that you don't give them more than 20 millimoles per hour, because you run the risk of causing hyperkalemia. Okay. So we've got a 4-year-old woman who's come in, taking a paracetamol overdose. She says she's taken around 25 tablets in the last 6 hours. You examine her, there's only a bit of abdo discomfort and some nausea. All her obs are stable. What would you want to do? Yeah, so you do ABC. ABC is absolutely fine. What would you want to do now? Yeah. So you want to take paracetamol level. Anything else with that? Yes, salicylate as well. Any bloods you'd want to do? LFTs. And what are you looking for in LFTs specifically? What, sorry? Yeah, so which? Yeah, it's the ALT. Anything else that you want to investigate as well at the same time? Yes, the INR. Those are the crucial things. Obviously, you're going to do your full blood count, you'll do use needs, you'll do everything. But what things you're looking for is the paracetamol level, the INR, and the ALT. Okay, and because that'll give you, as one of the girls in the crowd said, it'll give you a view, an indication as to how much hepatic necrosis is going on. Okay, so she's taken 25 tablets in the last 6 hours. You've taken the bloods, they've come back, or they're about to come back. What would you want to do to treat this woman?
You need to know whether she's high risk or not as well.
Okay.
There's no high risk.
She is high risk.
Yes, there's been a recent thing. We'll come back to that in a minute. So you're thinking now she's paracetamol levels are high. You want to treat her. What would you want to give her? Exactly. Yeah. And basically, in my handbooks anyway, and probably some of yours, unless the new ones have come out, there are 2 levels: the high-risk treatment line and the normal treatment line. Basically, get your books and cross out the normal treatment line. That doesn't exist anymore. There's one treatment line for everyone, whether you're high risk or not, and that's the high risk line. So you can keep your books, don't throw them away. But just bear in mind that the curve that's higher up for the normal people, that doesn't exist anymore. So basically, what the new guidelines say, they've got a lower threshold to treat people with paracetamol overdose. In terms of infusion-rated dose, I'd be surprised if you guys know it. You can do if you want to, but I don't think it's that important. You can always have time to refer to that. Basically, in case a few of you are unsure about what goes on, paracetamol gets metabolized by the liver. When it's an overdose, it becomes a toxic metabolite that gets metabolized and broken down by glutathione. When that's depleted, then the toxic metabolite increases, and that's what causes the injury to the liver and kidneys. And these are some of the high-risk patients, but that doesn't. You can take that into account because if you think that their liver is going to be more damaged than the average person, but it's not going to change your intention or threshold to treat them. So yeah, basically that's the treatment line you'll have in your books, and that'll say high risk in your books, unless you've got really new ones. But that's for everyone now. So if at 4 hours it's above, 100 milligrams per litre paracetamol level, that's when you'd want to start treating them. There's also a few other instances when you'd want to treat them straight away before the levels got back. Do you know when that is?
The dose is staggered.
Yeah, those are staggered. And one other thing as well.
Change within an hour.
Yeah, if you're taking within an hour, you can give something else. But there's a certain amount, if they're taken, that you can start them on treatment. If you think about 10 to 12 grams, if you're taking more than that, then you can start treatment.
Is there anything to do with like ages, like for kid payment?
I'm unsure if someone came in at 16. Not only consent, but about treatment as well. But I think that there is a lower threshold to treat them as well. Okay, so the woman you've treated has been started on Parvlex and acetylcysteine, and within a few minutes she's got all these things: the lip swelling, heart rate's gone up, her BP's gone down, and she's got an itchy rash. So what's happened? Yeah. Okay, what's the first thing you're going to do? Yeah. So ABCD and stop Parvlex, because that's what you know, that's what's causing it. If you're ever worried about you'll all know what the signs and symptoms are, but just in case, you can categorize it A, B, C, because you think A, the airway is going to get blocked up, stuff, some laryngeal edema. B, the breathing's going to be increased, it's going to be wheezy, swollen lips for C, all that kind of stuff. So it's quite easy to remember.
For the other scenario, when to give the charcoal?
The charcoal, you'd want to give it within the first hour. So if you know they've taken the paracetamol within an hour, then you want to give them the activated charcoal.
So,
And you'd want to wait 4 hours until you take your paracetamol level as well.
but it doesn't. People don't actually get a lot in hospitals, do they? Because they normally arrive after the hour.
You'll have a few. They're the ones who didn't want to actually kill themselves or present before 4 hours. A lot of them will present way later. And after 8 hours, if someone's presented and taken a large overdose, after 8 hours, they're at a high risk of getting liver cell necrosis. So the main management plans I just flicked onto. So you're doing your ABCD. What would you want to do next? You know that they're tachycardic and hypotensive. So what would you want to do? So you've stopped the Parvlex. Now what do you want to do? What's that, sorry? Yeah, so go back here. She's tachycardic, hypotensive. So basically she's in shock, isn't she? Yeah. So you'd want to give her some fluids, raise her feet as well off the bed. Who would want to give her adrenaline? Do you give her? How much would you give? Yes, you'd want to give 0.5 milligram, which is half in 1 in 1,000 concentration IM. Do you know what the IV dose is for cardiac arrest? Yeah, so 10 mils of 1 in 10,000, which equates to 1 milligram of adrenaline. Anything else you want to give after the adrenaline? Yeah, so chlorphenamine. How much? Yeah, 10 milligrams. Want to give that IV. Anything else? How much? Yeah, it's 200, between 100 to 200. But yeah, in the books it says 200 milligrams IV as well. Okay. And that should take you through the first little bit of the management. And obviously you'd give them fluids as well. If it got a little bit worse and they weren't responsive to treatment, you'd want to get your seniors involved, and you also want to get ITU as well. Okay. And that's my bit done. Thanks for that.
Right, guys. You guys are far too quiet, okay? So I'm going to make it really easy on you and just say, this is really simple, okay? You all know the answers, so don't be shy, don't be like, it's like, just be confident about it, because what have we got to lose? It's only me, really. So, this is scenario 1, okay? 30-year-old presents with hematemesis, okay? His obs are heart rate of 110, BP of 80 over 40, sats 94, temperature 37, respiratory rate 24, okay? So, what do you do?
Primary surgery.
What?
ABCD.
ABCD. Brilliant. Okay, so talk me through it.
What's his airway saying?
Chilling.
Okay. His respiratory rate is quite high.
Okay.
Give him some oxygen, yeah. 15
sure.
litres. Normally breathe.
Okay. So non-rebreathe.
Yeah.
He's vomiting.
Oh yeah. Nasal
Brilliant. Yeah, that's good. Does it make it easier if I go? Does that make it easier? You can picture it then.
Okay.
Oh God. Yeah. Help. Die.
Do you want to see?
Okay.
Yeah. What's his capillary refill? Two white ball cannulas.
Okay, wicked. You're gonna get a cannula in. Okay. Then with the cannula, you're gonna take bloods at the same time. So what bloods would you like to do? Oh, I can't hear you. Please speak up.
FBCs.
FBC.
Unit
Using it.
LSTs.
See that? Clotting. Group and save. Good. What group and save or cross match? Oh my God. What was that? Okay. So does everyone know the difference between a group and save and a cross match?
Yeah.
How much?
Like real talk. Does everyone know? Okay. So the difference is where a group and save is like a cross match, but an elective cross match. If you get what I mean. It's like, it's not, you can, if you know someone's going to go for a procedure in the future, they might lose a lot of blood, you'll do a group and save. So what happens is that gets into the blood bank, and they set aside some blood just in case. Okay, so it takes longer to do. Cross match is where you need it there and then. Okay, so that's all it is. That's my way of simplifying it. I don't like to think it might be wrong, but so far I think I'm right. Okay. So, what do? You don't panic and you remember your ABC, okay? It's really important. The OSCE station you'll get is very similar to, you know, how we just presented it. It's, you got an emergency situation, what are you going to do? So far the answer's always been ABC, so just don't go off that path. Don't overcomplicate yourself by thinking about the diagnosis first. Sort the patient out and then start thinking what's going on. Okay? So, airway was patent, they're talking, oxygen, nasal cannula if they're vomiting. If you can actually put a face mask on, but just be aware that they're going to have to remove it as well. Okay. So, breathing. Now, agonal breathing is where they actually just all of a sudden gasp for breath. They're not actually. You're going to have to like YouTube a video of it and have it. I can't explain it fully how it is, but it's not actually breathing. So that counts. That counts as a respiratory arrest. Okay. So just be aware of that. Okay, and be aware of aspiration as well. So, what about all this blood on the floor? Okay, so what are you going to do? We said we moved on to circulation. There are lots of blood that needs to be replaced. Do we agree?
Yeah.
Okay, so when inserting the cannula, we took bloods and we said it was full blood count, using ease, LFTs, clotting, cross match, maybe CRP as well, depending on where you work. And okay, so. If you're going to give blood, you can give them O negative, or you can cross-match 4 units. Okay, and that'll give them more of a, less likely for them to get reactions and stuff, but O negative should be fine, okay? So it just all depends on the emergency. So, do you guys know the difference between crystalloids and colloids?
Yeah.
What's the difference?
Where it goes.
Cheap.
Pardon?
Depends where it goes. It
Evidence
affects where
says
it goes.
nothing.
Okay, so this person, what would you give in this situation?
Crystal is cheaper.
Crystal is cheaper?
There's no difference evidence-wise.
No difference evidence-wise, yeah?
One's more likely to give you an allergic reaction than the other.
Yeah, cool. That's fine.
Just give whatever you've got.
Brilliant. Except for one thing. You wouldn't give when you're in fluid resuscitation dextrose. Why? Because it just gets metabolized way too quickly and it's just not going to help. So if you got a lot of people, if someone's blood pressure is kind of dropping, let's give them a stat dose of Gelafuse and let's see how it goes. So you can use a colloid. In someone like this, just get, you know what I mean, don't use dextrose, just bang on what you can. You know, give a litre stat. They've lost a lot of blood, okay? And do not forget to call for help, okay? Don't feel as though you know what I mean, I'm the hero, I'm going to sort this all out, and then, you know, don't, at the end of the day, it's a team thing, so always ask for help, okay? So, any imaging or other tests that you want to do? Imaging or other tests? Ultrasound. So upper GI bleed, what are you thinking of with ultrasound? Was that OGD?
Yeah.
Okay, anything else? So you can do your CT is more of a lot of times you can't really get a CT that quickly, okay? So chest X-ray, you can order a chest X-ray, but it's not always needed, okay? In the guidelines, it's not really well. I had a look and I couldn't really see much about chest X-rays, okay? But it can show a rupture of an esophagus, okay? Where you get areas around the arch of the aorta. So can you see? Everyone see that? Little air right there. Right there. You all good? Okay. So that can show, but really and truly, OGD needs to be done, you know, as soon as. Okay. So that's the kind of. So what we've done so far is we've managed them. We've got them on oxygen. We've got their. We've ordered some blood. We've got fluids running through them. That's fine. Let's say they're kind of stable. Now you want to try go for an OGD. But what else do you want to do? What if they come in with a load of medications? Okay. Warfarin, brilliant. So if they're anticoagulated or they're on antiplatelets, what are you going to do with those? Stop them. Brilliant. Okay, what else?
They're on warfarin, you can reverse the warfarin if their IR's too high.
Yep, brilliant. Okay, so what about other medications? So their blood pressure is low. Stop antihypertensives, brilliant. Okay, so you want to. The aim is to kind of get the blood pressure to a stable state. Okay, so if the blood pressure is low, stop medications that will make it low. Simple. Okay, like I said, just try not to overcomplicate everything. Okay, if you lose a lot of fluid, you can go into acute kidney injury. So you want to stop medication which might cause acute kidney injury. Okay, or anything that causes vasodilation. Okay. Were you with me so far? Was that a resounding yes?
Yes.
Thank you. So yeah, the aim is to maintain blood pressure. If they're on warfarin, does it need reversing? Okay. Does the patient have acute kidney injury? And are they on anything that could have caused the bleed? For example, if it's a bleeding ulcer, did they have aspirin or NSAIDs and stuff like that? Okay. So here's some causes for upper GI bleed. Although I'm covering the surgery side, a lot of upper GI bleeds won't get referred to SAU, they'll go to MAU because it's mainly seen as a medical problem, okay? And then you can debate whether or not to give them PPIs, but it's really, if they got esophageal varices, you don't really give them a PPI, it's mainly, you got to start thinking about using terlipressin, okay? So it depends what you think the diagnosis is. Does everyone know what kind of a mammary rice tear is? Yeah? I'm sure you've all kind of started revision by now, it's quite good. I didn't start till after February. Yeah, and it could just simply be a nosebleed. So just have a little think. So when we've managed them acutely, and now what do you actually want to know? So how much have they been vomiting up, over how long, colour, you just want to try to weigh up what's been going on. Heart rate goes up when the BP goes down, why? Compensation to maintain. Brilliant, yeah. So you want to, if you remember your physiology, that's how it goes. If the blood pressure goes down, heart rate kicks in to try and get more cardiac output and therefore increase the blood pressure. Okay. It's just make sure they're not getting peripherally shut down. How do you know if it's serious? Okay? Use common sense. If they look really ill, they're probably ill. Okay, if they just vomited 5 litres in front of you, don't start kind of like, I wonder, are they, really? Okay. And some places will use the Black Swiss scoring system, some will use the Rockall risk scoring system after an OGD. Okay, some places will use them both before an OGD and after. I haven't put them on because, I'll be honest, I didn't learn them when I was in 5th year. I'm not saying you shouldn't, but I'm just saying be aware of them, and you're not expected to kind of know them all off your head. But if you do have a look at them and understand how it's scored, then that will give you bonus marks in the OSCE. So when they ask you questions, cool, how would you assess this? Okay, so yeah, look at that. Okay, so that patient's managed, done. Okay, surgeons have come, rescued the day. You know, they've sorted them out. They've taken over. They've said, good job. Okay, you've kept them alive. Because that is as an F1, that's the main thing. In an emergency situation, your job is to keep them alive. Okay, if you want to, and hopefully take it further, but that's only if you've got the knowledge. Don't get out of your comfort zone, but you are expected to be able to do all these things. Okay? So, a 30-year-old man presents with a rectal bleed. Okay, his obs are yeah. Okay, does anyone notice anything about this scenario compared to the last one? Same obs. Wow. And it's the same age as well. What am I trying to say here? Is it the same person? Basically, it's practically the same management, okay? See, ABC, I'm not going to go through it all again because we just went through it all. It's the same management, okay? They've lost blood, something needs to replace it, okay? You don't want me to go through it again? Cool. Okay, it's that simple. And here's some lower GI causes, and PR bleeds are mainly handled by the surgeons. Okay, so yeah. So a 45-year-old male comes in with abdominal pain. Okay, so take a history. Ask me some questions. Just ask me some random questions. Okay.
Where is the pain?
Okay. Where is the pain? How can I explain this? Right there. So you've done your ABCD. Let's say you've got a cannula in. You're doing everything. You're taking your bloods. Okay. So, but what do you want to know? So you want to know where's the pain? So you do Socrates. We agree. Everyone remember Socrates? Cool. And it's generalized, kind of abdominal pain, and it's acute onset. Okay. What else do you want to know from the history? Past medical history? Not really much. Not much. Anything else? So someone comes in, I'm in pain, abdomen.
Is it constant or
Constantly there, yeah.
when did it start?
When did it start? It started after I got out of the pub. Okay,
When was that?
30 minutes ago.
Does it radiate anywhere?
To my back.
Head.
Pardon? It's really severe pain.
Does it hurt when you move forwards or backwards?
It just hurts all over. Help.
Have you had it before when you've been in the pub?
No, this is just, pain. Pain. Been in the pub, do you want to ask me how much I've been drinking?
You're a heavy drinker.
Please challenge me, okay? I don't actually drink in real life, I'm just saying, just as for scenario sakes, okay? So, what I wanted you to get from that is, I've been out drinking, okay? So, what kind of things are running through your mind now? Pancreatitis. Also? AAA, yeah? What else?
DU.
Perforated DU. Okay. So in examination, you've got generalized tenderness, kind of more severe in the epigastric and umbilical region. That's what you did on palpation. So what investigations are we going to do? Imaging wise? What kind of chest X-ray? Why?
Pardon?
Yeah, cool. Air under the diaphragm. So erect chest X-ray. You can do an abdominal X-ray as well. So, what bloods do you want to do? Louder, please. Amylase. Good. That's all I wanted to hear, amylase. Because anyone who comes in with an acute abdomen, you always do amylase. Okay? Even if it's pain on the right-hand side, left, right, always do amylase. Never forget that, because if you miss it, it's serious. Okay? So, you also might want to do a group and save if you feel as though they're going to need surgery. Okay? So, what if the amylase is borderline?
Do lipase.
Lipase or
Urine amylase.
urine amylase. Why?
Excreted within 12 hours.
So if the if the amylase is borderline, why is the urine amylase and the lipase going to be a better shout?
It's in urine for longer, like in the blood.
Yeah,
That was decreasing in about 12 hours.
that's right. Amylase has a shorter half-life. Okay, so you don't know whereabouts you've actually caught it. So if it's borderline, could be caught it too early and it's just rising, or it could be coming on the way down. You don't actually know. So you do urine amylase or lipase, depending on where you work. Okay, so we've got an idea. It's pancreatitis. What are you going to do? What?
Fluids.
Fluids. Nil by mouth. Analgesia. Okay. So, what kind of fluids are you going to give him? What? Say that. No, how much? Let's say how much. Forget what. How much? Quite a lot. A litre over what?
8 hours.
8 hours, okay. Any more takers?
What's the blood pressure like?
Blood pressure is slightly low, okay. So let's say you've already given them their fluid challenge, and their heart rate and BP are now stable, okay. So as if someone came in, their heart rate and everything was stable, and they said, right, we've got pancreatitis, okay, give me a fluid regimen.
They just need maintenance fluids.
Will they? No. No, why not? No. If they said, oh, they know. Why?
You get third space loss.
Third space loss. That's right. So you get a lot of fluid loss in pancreatitis, okay? So usually, I don't know about in Leeds, but in Bradford we give them a 2-hour bag, then a 4-hourly bag, then a 6-hourly bag. And then we top them up if needs be. Nil by mouth. The pancreas needs to just rest. Okay? It's inflamed, it needs to, yeah. Cool. So, do a Jackson 5 and ABC. A lot of third space fluid loss. Give a 2-hourly, 4-hourly, then 6-hourly. Keep them nil. And use the pancreatitis scoring system. Does everyone know that? Yeah, spells out pancreas. I'm not going to ask you to just say the numbers. So analgesia. Remember, if you're going to give, you're always going to go on the analgesic ladder, okay? But here's where, in my OSCE, I said, alright, cool, they look like they're in a lot of pain, I'm going to give morphine. They asked me, how much, okay? I said, IV morphine. She looked at me a bit odd. It just showed that I've not been on the wards. On the wards, it's very rare that you will give IV morphine. Okay, it doesn't matter what it says in the books. Okay, because everyone wants to see, have you been spending time on the wards? Do you have experience with these sort of things? You normally give IM morphine, and it's usually about 5 to 10 milligrams. Okay? In A&E, you might give IV morphine. SAU, not really. I don't know about Leeds, but
Not much.
yeah. So IM morphine. Okay, so you go up the analgesic. You say to them, "I'll go up the analgesic ladder. I'll start off with it." They'll look at you. Yeah, cool. It's very, very, very painful. And you say, IM morphine. Okay. Don't forget your cyclazines and your antiemetics and all sorts. Okay. Learn your doses for simple, common drugs. Okay, like your cyclazine, 50 milligrams TDS, IM morphine, tramadol, codeine. Just that. It's really, really simple. Okay. So causes and scoring. Causes of pancreatitis. Get smashed. Done. Okay. What are the important ones out of that? ERCP. So the main 3 that I remember. Trauma, I don't remember that much. It could be important, I guess. But if someone says causes of pancreatitis, okay, say to them, if you really want to impress them, say, right, there's the pneumonic get smashed. However, the common causes of pancreatitis are you do CT to confirm as well, pancreatitis, is alcohol, gallstones, ERCP, and also trauma as well. Okay, those are like the common ones that you'll see. Okay, and they'll think, right, this person's not just reading out of a textbook. They actually thought about it and know what's common, what's not, what they're more likely to see. Okay, here's the scoring system, how you score it. If you rearrange it in order, it says pancreas in some weird way. Okay, but yeah, a lot of the time they'll have a pancreas. In Bradford we have a sheet which has it all on, so you don't need to remember it, which is great. But then, obviously, if someone asks you, you might. Yeah. So you want to add on these bloods. Also, you want to check for triglycerides, like do your lipid profile, cholesterol, because they'll change as well. So, okay. Now we were talking about perforated DU, erect chest X-ray. What do you see? Area of the diaphragm. Perforated DU. Okay. You've done your bloods, you've done everything. It's not. Call your seniors. They will need to go to either ICU or just go straight to theatre. Okay. No messing about. What if the pain was somewhere else? Okay. What if it was right iliac fossa pain? What if I was a woman? Okay, so you've got your ovarian cysts, you've got your appendicitis. There are loads of other, in women there's loads of other kind of differential diagnoses that are just not in men, because different bits, obviously. Okay, so in terms of, the reason why I bring up ovarian cysts and appendicitis is because everyone will jump to appendicitis, okay? But the history is quite different in an appendicitis and ovarian cyst. Okay? History, does anyone know the differences? So if I said to you, okay, take a brief history from me, go on. And I'm a woman, okay?
Where is the pain?
Right there. Right.
Has it gone anywhere else or started anywhere else?
No. It's just come on right here.
How quickly did it come on?
It came on about 2 hours ago, it's not left.
Have you ever had it before?
No.
Was it sudden? It came on?
Sudden came on.
How severe?
That's really severe, about 8 out of 10.
Have you still got your appendix?
Pardon?
Have you still got your appendix?
Yes. That's a really good question though. That is a very good question, because a lot of people, it's like, right, I've got right upper quadrant pain, yeah, I've got this, alright, cold, yeah, does it radiate to the shoulder tip? Yeah, man, it's cholecystitis. All of a sudden, past medical history, yeah, cholecystectomy about 20 years ago. Okay? So, that's really important. Really good question to ask. Okay? So what I was trying to get at there is, an appendicitis usually starts off as general abdominal pain, then radiates to the right iliac fossa. Ovarian cyst just goes straight to the right iliac fossa. Okay? Sudden onset, acute. Okay? And also, appendicitis will also put you off the food. So, if you are taking a history from someone with an appendicitis, ask them, are you hungry? Okay? Because if they are hungry, you're thinking, one sec, maybe not, okay? Maybe it's really mild. Okay, so are they hungry is really important. And also make sure you do a PR. Okay? Anyone with an acute abdomen must have a PR. Okay? Yes. Have you guys met Mr. Griffith? Try to work on SAU and not do a PR in front of him. Watch. And just see what he does to you. He'll just make you cry. Not me, obviously. He's like my boy, so. So yeah, so make sure you do a PR, okay? You might be thinking, oh, it's not really going to show anything, but if you don't do it, it might be seen as negligence, okay? So complete your examination. So, also in appendicitis, you get a bit of rebound tenderness, Rosings, which is pain when you compress in the left iliac fossa and it hurts more on the right. And also there's, I can't remember what the sign is called, but if you get them to flex their hips.
So a sign.
Yeah, so a sign. So if you get them to on hip flexion, it causes more pain. Okay. So imaging modalities. You can do ultrasound, yeah. You can do a CT. You can even just do an exploratory surgery. It depends what you think it is. Definitely get a senior review as well. So surgery on 38-year-old female, okay, vomiting brown liquid for 2 days, okay. So what kind of questions are you going to be asking?
Does it smell?
Yes.
How much are you vomiting?
Loads. Every time I eat, I vomit.
Have you opened your bowels?
No, I haven't. How did you know?
Have you passed any gas?
It's personal, okay? Women don't, pass air. Yeah, I haven't passed any gas. Okay. Really good. I'm really impressed by you, actually. I'm glad. Not many people get the whole passing flatus. Okay. So what are we thinking? Obstruction. Brilliant. Okay, so not up on my bowels for 3 days, no flatus, generalized kind of abdominal pain, past medical history, cesarean 2 years ago. Okay, so you know the drill. ABC. We're not gonna go through everything again. I know you know it. I know you know it. Chill it. Okay. So blood. Don't forget your amylase. Okay. And I'll explain why later. So imaging. You want to do an erect chest X-ray and you want to do an abdominal X-ray. Okay, because you don't want to miss a perf, but you want to see if it's obstructed. So, did everyone see that? Cool. I was meant to animate it so you couldn't tell which one was which, but you know what? It doesn't matter. Okay, so large bowel obstruction and small bowel obstruction. Try to learn the differences because it'll make your life a lot easier. Okay, if it's central and kind of looping, then you're thinking, alright, cool, it's more likely to be small bowel, and also the width as well. It's about not greater than 3 centimeters. Yeah, something over 2-3 centimeters. I can't remember the exact width, but if it's larger than that, let's say 5 centimeters, it's more likely to be large bowel. Okay, and also you can see it's kind of more at the sides. Okay. Does anyone know what the lines going across are called? Haustra. And what about the small bowel? You guys whispering way too much. Come on, just say it. You said it right. Thank you. Your confidence. Don't be saying that to the exam. In the exam, we're going to be. Okay.
What are they called?
A valvular convente. Okay. Okay. So. The difference is Haustra go halfway, the other one goes all the way across. Okay, so that's another way you can tell. So really simple stuff. Okay, so what are the treatment?
Nasogastric tube.
Nasogastric tube. For which one? Both of them?
Yeah.
Okay. So nasogastric tube also. Pardon?
A wide bore nasogastric tube.
Yeah, sure. Wide bore nasogastric tube. Good.
Nil by mouth.
Nil by mouth. IV fluids. Brilliant. So. It's called drip and suck because basically you're sucking out all the bad stuff and you're putting them on a drip. Chilling. See, simple. Okay. See, they're not getting fluids, so therefore you're giving them fluids. Wow. It's like medicine's so hard, isn't it? Just make sure you break everything down into simple things, and it'll, trust me, your life will be a lot easier. Okay. So nil by mouth, drip and suck, IV fluids, and an NG tube. Okay. Large bowel obstructions, it's usually treated by surgery, okay? So unless it's a sigmoid volvulus, okay, in which sigmoidoscopy and a flatus tube is, don't know what a flatus tube is, and fecal obstruction, enemas, okay? So, does anyone know what a paralytic ileus is? Pardon? I can't use...
No movement.
No movement, okay. Give me one cause of no movement. Surgery, yeah. So a lot of the times after surgery, people will find it difficult to pass, to have bowel movement. Why? Because for some reason the bowels just don't want to move. Who knows? Yeah. So that will recover usually by itself. Okay. And it also can be caused by pancreatitis. Hence why when we were doing bloods, we did. Good. Okay. So the treatment of a paralytic ileus is very similar to small bowel obstruction. Okay. So causes, give me 3 causes that you should just be able to just throw at me.
Malignancy.
So let's call it masses.
Adhesions.
Adhesions.
Hernias.
Hernias. Brilliant. That's all. That's all I want to know. Okay. So 3 ones that should just come straight at you. Okay. Are those. Then you've got intraluminal stuff, which such as like fecal impaction. Things like that. So what caused this lady's obstruction? Adhesions. Why? Thank you. See? Okay, so now, 40-year-old male post-op from a Hartmann's procedure, spikes the temperature. Okay, so you're on the phone to the staff nurse. Okay, so what are you going to do?
Get the rest of the obs.
Okay, ask for the obs. Okay, they've designed like like a little mnemonic for speaking over the telephone. S-bar, yeah, because you can get that as an OSCE station as well, where they'll go behind, okay, you pretend to be behind this cloth and you pick up the phone and answer the phone and be like, see, I can't do a Filipino accent, we have a lot of Filipino nurses, so I'm just going to do an Indian accent, okay? So, doctor, okay, I have a patient who's spiking. What do you want to know? Come, talk to me.
Where are you?
Where are you?
What's the temperature?
SAU. 39. He's a Mr. Griffith patient who's post-op from a Hartmann's procedure, and he's just spiked the temperature, now, of 39.
What's he using?
I'm using at 4.
What's he normally using?
No, 0.
What's the other observation?
What is other observations? Respiratory rate. No, BP is 90 systolic. Heart rate is 90. SATs are 94% on room air. Stuff like that. Okay, so then what are you going to tell? What else?
Is the patient in pain?
Not really. It's not really. GCS is kind of reduced. So you can't really say he's just. That's what he's like. That was my impression of the patient.
What medications are you already on?
He is on Fragment.
Is there any antibiotics?
No.
Have you done a blood glucose?
Blood glucose is fine.
Have you got him on oxygen?
No, not yet. That's a good thinking,
Would you like
doctor.
to do that?
Don't tell me what to do. Yeah. Yeah. There you go. Cool. We're going to put them on oxygen. Okay, what else are we going to tell the nurse to do? Frequent monitoring. So you got them on oxygen. Make sure, perhaps get a few things ready for you. Ask them, okay, can you get some fluids ready? Get some blood needles and culture bottles out ready. So when you get there, you can get started. Okay. Just think about how you want to prepare. Just think what you're going to do when you get there. Okay. So S-bar. Yep. Recommendation. So OBS, yeah, so maybe I was a bit wrong with the OBS, but yeah, my bad. So we said what we're going to do, but also, so what are we going to do? Rhymes with PVC?
ABC.
ABC, brilliant. Okay, so you've got that. So you know the kind of history. History is not really he's monged out. Sorry, he's a bit. His GCS is quite reduced, okay, so you can't really take a clear history. He's not really. I guess he's complaining of pain around, the site, okay, site of the wound. Okay, so investigations. Bloods. Do we all agree we want to do some bloods? Which bloods in particular?
FBC.
FBC, good. What are we going to see in the FBC? What do you think we're going to see?
White cell rate.
Raised white cell count. Go on, next. Using these. What might we see?
AKI.
What?
A bit of AKI.
Maybe, yeah, depending. Brilliant, yeah. So urea's slightly up, nothing to concern you about. That's good. Also?
Cultures.
Culture's brilliant. Culture's really important, okay? So, anything else? CRP, yeah. Surgeons love CRP.
How far post-op is it?
Let's say 3 days post-op.
Because the CRP wouldn't tell you very much because it's probably a CRP from surgery.
Yeah, but it'll be good to see if it's rising or not, isn't it? A lot of people, I agree with your point, and if you missed it, it's perfectly valid. You can say to them, look, there's no point because it's not going to raise much, but a lot of surgeons might tell you off. But you have got a valid point, and Yeah. I'm not going to say you are. Okay.
ABG.
ABG. Right. Why? What part? What particular part of the ABG? Lactate. Okay. So we want to see lactic acidosis. And why do we get lactic acidosis? Why do we get a build-up of lactate? So because of anaerobic respiration. Okay. So it's poor tissue perfusion. So yeah, using these ABGs, cultures. You might want to swab the wound as well. Okay. Also, you don't know if it's from the wound. It could just be a urine infection. Okay. There's a few things that will cause a temperature of 39. Okay, or above 39. One of them is kind of pyelonephritis and also UTI. They can urinary sepsis. Okay. So we're going to do some X-ray imaging. Why might we want to do X-ray imaging? Because we don't know where the infection is. Do we agree?
You could have a hospital-acquired pneumonia.
Yep, hospital-acquired pneumonia. Okay, so we want to rule that out. Okay, ECG, maybe look for signs of ischemia. Okay, so if you kind of have a rough idea, let's say the site's a bit, looking a bit dodgy, looks a bit infected. Okay, what are you going to start them on? One of them's already given. Paracetamol for the temperature. Do we agree? What's the dose? 1 gram QDS, good. Okay, and empirical antibiotics. So a lot of places will like to use Tazantike. A lot of places, if it was an intra-abdominal sepsis, it could just be Kefenmet. With this, you could just be able to give flucloxacillin. Okay, if you think it's some sort of cellulitis, depends. Follow the local guidelines. Okay. Okay. So let's say I was playing football. Okay. And yeah, let's just say it wasn't fun. Okay. So pain in testicles. I'm just okay. What are you thinking? It wasn't actually me. Don't worry, this wasn't me at all. So I'll take it back. Yeah. So now you're thinking torsion already. Yeah. So that's one of the emergencies. Okay. So from the history, you're going to get pain in testes, possibly right into the suprapubic area. Okay. What are you going to do with this patient? Call the surgeon. Why?
Because you've got 4 hours.
Yeah. You've got 4 hours until the testes becomes necrotic. Okay? So, what kind of things are you going to see in examination?
Is the pain relieved by lifting?
Is it?
It's not important.
It's not. Nope. That's what. If it's relieved by when you lift the testicle up, then that's called a positive Prain sign. Okay, and that means that it's more likely to suggest epididymitis rather than torsion. But if it's painful either way, then you're thinking torsion. A lot of the times, the urology registrar will already know about this patient before you do. Okay, but just in case if he doesn't, this is how you spell them. Okay. Okay, so treatment is ADC. Don't forget. Okay, do bloods. Imaging. Do you want to do imaging with this patient? No. Okay. If you just want to rule it out and you don't actually think it's testicular torsion, you can use ultrasound Doppler to confirm it, but that could delay treatment. So, really, it's exploratory surgery. So you're right. Okay. Now, this is not going to cover all the surgical emergencies. The one that I got in my OSCE was, patient was there, looks quite ill, what did you do? And it's just simply running through what we just did. ABC. Very simple stuff. What blood tests would you do? Painkillers would you give them? Oxygen levels. They might ask you how to score the patient. So if it was a pneumonia, you'd say use the Curve 65 score, things like that. Okay. In the OSCE as well, we got an ABG. I said it was respiratory acidosis when in fact it was actually a mixed. Okay, so just be aware of that. For any questions at all now? to either one of us. Okay.
With an ovarian cyst rupture, do you get peritonitis?
Only if, well, to be honest, it won't really cause peritonitis as such, but it's caused a lot of pain. But it can become peritonitis. Okay, so it's really hit and miss. Depends
If
on.
it wasn't a testicular torsion, would you pay? What else would you be thinking?
You could just be thinking, I just got kicked in the nuts. Okay, I was just playing football, I was kicked, it's really painful. Okay, then you've also got epididymitis, epididymal-orchitis, you know, things like that.
In orchitis especially, the testicles swell quite a lot.
Yeah.
I've seen one the size of like a tangerine, massive. So,
Okay. Any other questions at all? No? Right, guys, just a little bit of general OSCE advice, okay? Okay, just chill, okay? You are in all honesty, I can't stress to you how nervous people go into this, because I was absolutely bricking it when I walked into mine, and I was like, my name's da 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 da, and it's just, do you know what? You're just having a conversation. You can ask random people on the street their names. So why can't you just ask this person who's just sitting? Actually, some people can't ask random people in the street their names, but practice it. If you get quite anxious about talking to like strangers, or you feel as though just put yourself in a position where you actually get anxious, and just throw yourself and get used to that. Okay, and just don't make it too serious. You know, really don't make it too serious. I got really nervous, and I said, "Oh, how much alcohol do you drink within a year?" He looked at me and I was like, "Well, I can't really tell you a year." And then I realized what I said. We all bursted out laughing, and it was just fine. Okay, it's really you've made it through fourth year. Fifth year is a doddle compared to fourth year. Okay, I'm not saying don't work hard. Work hard because you know this is the last push. So there's no excuse for not working hard. Okay. But if I can make it, trust me, if you see what I used to be like in first year compared to now, you've all grown up without even realizing it, okay? So don't think that you can't do it, you're not ready for this job, because that fear will sometimes never go, but you just got to get on with it, you just got to face it, okay? So, stop overthinking, okay? Keep it nice and simple, and have a system, logical way of thinking about it, okay? If it's acute abdomen, think about the anatomy. If they're right upper quadrant, don't start thinking, okay, maybe it's the rectal carcinoma or something like that, okay? Just go with the anatomy, okay? ABC, ABC, ABC. That's for your emergency OSCE station. Okay, thank you. By the way, girl in the front, you've answered the most questions, so did you want the chocolate?
Thank you. Mum and Dad.
Oh, that one.